Great. I'm going to get started. A big welcome to everyone joining um, from around the world. It's really wonderful to be having our first webinar on for the Health Equity Innovation Series. My name is Sian Brown, and I'm the Health Equity Lead here at Stanford Biodesign. This series is actually has been around for about a year and a half now, and it's a monthly session where every month we bring in innovators, academics, and various people who are interested at the intersection of health equity and innovation. And the idea is to catalyze conversation and learning about important themes in health equity and innovation. Before I begin today, I'd just like to thank our partners, the Center for Innovation and Global Health here at Stanford, the Bay Area Global Health Alliance, and the Stanford Global Health Graduate Network for joining us to make these events happen. So I'm very excited for today's project. We're going to be hearing from a team in Chile. That's actually an international team. And the DASON Project aims to improve pediatric feeding care around the world by developing a novel securement device that allows Foley catheters to be used safely and effectively as gastrostomy tubes in limited resource settings. So today, the DASON team is going to be sharing their insights around cross-cultural collaboration, student-supported innovation, and low-cost global health technology. I'm going to share a little bit of who the team is, and then I'm going to be handing over to Patricia, who's going to share this info in Spanish for those of you joining that would like to hear this info in Spanish. So Kathy is an MD, MBA student here at Stanford, and she's actually the leader of the DASON project. She's passionate about developing accessible innovations for marginalized communities worldwide. Kathy studied biomedical engineering at Johns Hopkins University and has founded several award-winning ventures focused on low-cost maternal and pediatric health technologies. Dr. Joan Petillo Silva, MD, MBA, is a pediatric surgeon at the Pontificia Universidad Católica de Chile. He's the Chief Medical Officer at the UC Christus Clinical Hospital and the Principal Investigator of the DASON Project. Patricia Frientes is a designer at Pontificia Universidad Católica de Chile and a design lead of the DASON Project. He teaches classes on healthcare design at PUC and is currently pursuing industrial design and engineering certification at MIT. So we really have a stellar lineup in terms of the team today. Thank you so much for sharing your insights and expertise. I'm going to hand over to Patricia. And just a reminder that for those of you joining online, feel free to submit your questions throughout the session. We are going to have a session Q&A at the end of today's talk. So over to you, Patricia.
Bueno, hola a todos y bienvenidos al evento de hoy. Saludo a quienes nos acompañan en línea desde distintas partes del mundo. El proyecto DASON busca mejorar la atención de alimentación pediátrica en todo el mundo. Esto mediante el desarrollo de un innovador dispositivo de sujeción que permite utilizar sondas Foley de forma segura y efectiva, como tubos de gastrostomía para niños en contextos con recursos limitados. Y en este seminario web, como equipo DASON, compartiremos nuestra experiencia en colaboración intercultural, iniciativas de innovación lideradas por estudiantes y desarrollo de tecnologías sanitarias de bajo costo. En cuanto al equipo, primero tenemos a Katy Hu, que es estudiante de medicina y MBA de la Universidad de Stanford y líder del proyecto DASON. La apasiona desarrollar innovaciones accesibles para comunicaciones marginadas alrededor del mundo. Katy estudió ingeniería biomédica en la Universidad Johns Hopkins y ha fundado varios emprendimientos premiados enfocados en tecnologías de salud materna y pediátrica de bajo costo. El doctor Juan Carlos Patilo Silva, MD, MBA, FACS, es cirujano pediátrico en la Pontificia Universidad Católica de Chile, director médico en el Hospital Clínico UC Christus y el investigador principal del proyecto DASON. Y yo, Patricio Fuentes, soy diseñador en la Pontificia Universidad Católica de Chile y líder de diseño en el proyecto DASON. Imparto clases sobre diseño en salud en la misma universidad, Pontificia Universidad Católica, y actualmente estoy cursando una certificación de diseño e ingeniería industrial en el MIT.
Okay. Hi, everyone. Thank you so much for joining us. Welcome to our talk about Project DASON, our journey to improve pediatric feeding care in resource-limited settings. On behalf of our entire international team, we're so excited to share our story with you today. So, gastrostomy tubes, or G-tubes, allow children with feeding difficulties to receive nutrition directly into their stomachs. Children may need feeding tubes for a variety of reasons, including swallowing disorders, digestive problems, neurological conditions, respiratory problems, among many. Proper nutrition is especially vital during childhood. This is a period, it's a critical window for growth and development for children. So it's really, really essential that children worldwide are able to receive the nutrition they need during this time. Worldwide, more than 10% of children rely on feeding tubes. This includes over 200,000 children in the US and much more in low and middle income countries, shown here in red. And these countries, these low and middle income countries, are where 90% of the children in the world with birth and feeding deficits are born. So today, there are a variety of gastrostomy tubes ranging from small ones to long ones, but the current gold standard for pediatric feeding tubes is the low profile gastrostomy button, as you can see here. This button was invented about 30 years ago, and these tubes were essentially designed to be discreet, secure, and reduce the risk of displacement. As you can see here, they're like low profile, so they sit pretty flush to the skin. And this is supposed to prevent the tube from getting caught on things, from getting pulled by children. And it's supposed to essentially minimize complications associated with some of the other previous gastrostomy tubes, which are a little bit longer. To feed through these gastrostomy tubes, you normally just put in an extension tube and then you kind of disconnect it when you're done feeding. So overall, most of the time, it kind of stays like that with a pretty low profile, discreet and hidden under clothes. These gastrostomy buttons are now pretty standard in many like high resource settings across the globe, including the US.
But the reality here in Latin America is that most children do not receive this bottom. This is not because they don't need them, but because these technologies are simply out of reach for them. The cost of this bottom is nearly $150. That's about half of a family's monthly income in many parts of Latin America. We can look at Venezuela's, Argentina, and Peru monthly income. And even in the upper half, like Chile, we still are very close to the cost of a bottom. So this so-called gold standard is not feasible solution for these families. The bottom is inaccessible and unaffordable for many of the families who need it the most. Well, that's where frugal innovation becomes essential. It's about closing the gap between new advanced technologies and resource-limited settings by designing safe, effective, and affordable solutions that work with the realities of communities that they serve. Frugal doesn't necessarily mean fragile. When well done, frugal innovations are safe, rigorously tested, and adaptable across diverse settings. Many of the world's most impactful health technologies are low cost, validated, and intentionally simple. We have some examples here for you, like the GE's Mac 400, that's affordable ECG machine made from local bus ticket printers. Also, mosquito net used for hernia repair, a great example of how everyday materials can be used safely in surgical contexts. The nets have been validated to closely resemble the mechanical biological properties of abdominal walls. Then we have the Kalman catheter tamponade. This is to manage postpartum hemorrhage, which is a simple combination of widely available condoms and Foley catheters in the medical context. Each of these shows how simple tools can dramatically expand access to care in low-income settings.
So when it came to our project, we asked ourselves, how can we apply frugal innovation to pediatric feeding tubes? And everything started with a multidisciplinary course given with the School of Design and Medicine. In this course, we challenged the students to learn to apply innovation principles to clinical problems. So I was invited to lecture on pediatric surgery, and I give them a brief and a broad spectrum of what do we treat in pediatric surgery. And that lecture sparked a wave of ideas, and the students began research on multiple challenges faced by our pediatric patients. As they engage more deeply, taking with health providers, caregivers, and patients, one problem stood out in particular. In the public hospitals in Santiago, we met many children using Foley catheters as feeding tubes, either because their families couldn't afford a button or because buttons weren't available. These catheters are widely available and cost around $1, a much more accessible price. But they're not designed to be feeding tubes, especially not for children, who, as you can see here, often pull out a bit on them, leading on complications and accidental dislodgement. There is also no standardized way to secure a Foley catheter, so caregivers and staff resort to makeshift methods, such as silicone tubes and septis. As you can imagine, this results in high rates complication. Nearly 40% experience problems such as tube migration, tissue irritation, and more. So the need was clear. We needed a safe, affordable way to secure Foley catheters we use as feeding tubes in children. So that's when DASON was born. In 2017, with the UC design students, we developed the DASON, a securement design that allowed Foley catheters to be safely and effectively used as feeding tubes. We create an early prototype using design methodologies, enter competitions, and join the Haptech and Oxentia incubator programs. We save major pushbacks on the business case. We tried to fill a patent, but UC Chile was hesitant to support it since they didn't find it commercially viable, and we had to finance it ourselves. So we decided to pivot. We have now embraced in an open source model because we want this technology to be available and accessible throughout the world. Then the pandemic hit, our studios graduated, and the project stalled.
So then, like a few years later, after the pandemic, after some of the students graduated and the project stalled for a little bit, in 2022, I was a first-year medical student at Stanford looking for global health innovation projects. We had kind of a summer between our first year and second year to be able to do like research, and I was especially interested in low-cost pediatric technology, so I was searching for research in that field. But Stanford had only kind of a few global pediatric innovation projects, and I couldn't find what I was looking for there, so I decided to kind of look elsewhere. I ended up cold emailing professors in Latin America. And ultimately, I'm very, very grateful in the end that Dr. Patillo responded to me. And kind of like from there was where our partnership formed. With the support of some of my mentors at Stanford, including Dr. James Wall, who was the head of Stanford Biodesign and a pediatric surgeon as well, we proposed this project to revive the DASON device and validate it in proof of concept studies, in clinical and mechanical studies in Chile that summer. So to actually make this happen, we formed a cross-cultural, cross-disciplinary team from the US and from Chile. On the US side, I had the support from my medical school and from Biodesign. From the UC Chile side, we had our clinical partners, we had designers, engineers, and also we brought in Hospital Josefina Martinez, which is a private public pediatric hospital on the outskirts of Santiago for our clinical study. And overall, what made this team so special was the international and interdisciplinary collaboration. Our team from the US, we brought student support and we brought Stanford resources. And then our team from Chile brought the clinical need and brought kind of the local experts with really deep contextual knowledge. It was like overall a really true equitable partnership, and everyone played a crucial role in the project. So in summer 2023, we started these proof of concept clinical and mechanical studies. This is when we kind of revived and we tested the prototype for the first time. On the left, you can see here is kind of one of the original versions of the prototype. We hand manufactured each unit for less than $5 USD. And you can see there's like a 3D printed cap, and then this silicone base, which was also hand poured and hand casted from medical grade silicone. We ran a small clinical study with 10 pediatric patients over 2 weeks at Hospital Josefina Martinez. And like I said earlier, this is a kind of a public-private pediatric hospital on the outskirts of Santiago. It receives its like funding from private sources, but overall it treats patients in the public healthcare system here. And it is for children with chronic respiratory disorders. So most patients were chronically hospitalized and were indeed using Foley catheters as G-tubes. We also, as you can see here on the very right side, we conducted a mechanical study in parallel to see how our device could help the Foley catheter improve kind of resistance in general of the tubing to pull forces. And overall, from these from these studies, feedback was pretty encouraging. It showed that our device was safe and functional, but also that we needed to improve the durability and ease of use of the device. As like in the clinical trials, some of the pieces, you can see here kind of the silicone base and the cap tended to fall off with frequent use. So since then, in the past 2 years, since our initial clinical and mechanical studies, we've redesigned the device extensively. We've brought on more Chilean students in design and in medicine, and together as a team, we've iterated on multiple versions to be able to strengthen the prototype in response to some of the feedback we received initially. And the new DASON shown here is more robust and now more easier to use. The cap part only has one part, the silicone base also is only one part. And now we're conducting mechanical validation studies at this moment, trying to make sure that our device is robust, it's safe, and it's durable to use. And we also have a even larger clinical study ongoing right now. This clinical study is also at Josefina Martinez, and it's with a new prototype, but it's involving over 20 patients and for an entire month. We're also currently conducting focus groups with caregivers and healthcare workers at various hospitals around Santiago. And this will essentially help us learn a little bit more about caregivers and medical staff's experiences with G-tubes and Foley catheters, as well as get candid feedback on our device. And so far, our results have been really promising. The feedback has been very positive, and we are really, really excited to see the final data soon. Overall, the feedback we received has shown that all the improvements we've made kind of in the past few years have been well received, and the version of this device is really working. So it's something that we definitely will continue with, but that doesn't mean that we're going to stop right there. With the feedback we receive, we plan on continually improving the device. So in the past 3 years, DASON has grown far beyond what we've imagined. Our team has been incredibly grateful for the opportunities and the recognition that have come our way. We've presented in international conferences, we've published our findings, and we also received major grant support to continue advancing our innovation. Looking ahead for the future, we hope to start reaching out to nonprofit and industry partners to help us scale up manufacturing and also, more importantly, expand access to other regions of Chile and throughout Latin America. Because we know, although this, using Foley catheters as G-tubes is a problem is a reality we've encountered in Santiago, in the outskirts of Santiago, we know that it is prevalent throughout Chile and also throughout Latin America and throughout, in general, like the world as a whole.
This project has shown us that cross-cultural, cross-disciplinary collaboration and student support have been essential for frugal innovation. Frugal innovation isn't just about building a low-cost device, rather it's about who you're building with, who we are collaborating with, and the support you are driving the project forward. We'd like to close with a few recommendations for anyone that's trying to do something similar in frugal innovation. First, center local voices and contributions. This includes local communities in need, people who are having the problem, as well as also the collaborators, people who are trying to fix the problem right now. In our case, we try our best to connect with patients that are the people having the problem right now, and caregivers and incorporate healthcare workers in our team. Secondly, build from local solutions and resources. This is called asset-based community development, using the resources that are already available in communities so your solution is realistic and sustainable. We met the community where they were, working with their reality of the Foley catheter use, not around it. We also recommend innovating in areas which people have already tried to make solutions, but perhaps they might not have worked. So you know that it's an area that communities actually need and want innovation. Thirdly, support students, innovation, and leadership. Students have time, creativity, and motivation, often with fewer constraints than the other. From our own experience, we've learned to take initiative, to seize opportunities when they exist, and create them when they don't. Being a student shouldn't be a limitation. It can be your unique strength. Also, surround yourself with interdisciplinary mentors and don't hesitate to ask for support. And for mentors, your encouragement is crucial for these projects. When students are empowered and supported, they can help drive real, meaningful solutions and innovation.
So thank you so much to everyone for listening. We're super, super grateful to our entire team here, most of which shown here, but a lot of people who aren't shown. This comprised of healthcare workers, designers, engineers, and students from all around the world who have helped in each of their own ways, shapes, and forms bring DASON to life. We also want to thank especially a big thanks to the staff at Biodesign, especially Cyan and Anchi for this opportunity. And lastly, a humongous thank you to all the patients, the caregivers, and the study participants and staff that have shaped this project. This overall is just kind of the beginning of what's possible when you combine equitable innovation and global teamwork. And now we can't wait to see what the future holds. So yeah, thank you so much. And I'll give it to Cyan to moderate for some questions.
Great. Thank you so much, Kathy, and to all of you. That was such an interesting session. And I think what I really appreciated and took from it is you really told the story of how you bring together all these pieces of both the hospital network, clinicians, designers, engineers, and communities to make a project like this happen. Because very often we present it when it's finished and complete, and people don't get to see the backstory and understand the inner working. So thank you so much for sharing that. We are going to open it up to Q&A. So if you have a question, we're going to get to that in a moment. Feel free to also ask your questions in Spanish or English, whichever you prefer. And if you'd like someone in particular on the team to answer the question, just type their name at the beginning of the question, please. So there is a question waiting, but before we get to that, I would love to ask the team. So we've actually touched on frugal innovation in the Health Equity Innovation Series in past year. And one of the things that I think keeps coming up is frugal innovation has transformative power to make innovation more accessible, but the business model behind it is very complicated, as IP can also be complicated, because ultimately this is about access, not always profit. And I know your team had some interesting learnings there. I wonder if you can share with us what you've learned about potential business models or lessons around that specifically for frugal innovation.
Yeah, thank you so much for that question. I'll actually leave it to Dr. Patillo to answer that question, because I think him and the start of the team at the very beginning really navigated pretty interestingly, like the IP and the space.
Yeah, so when we started with the project, we thought initially to assess the feasibility, to escalate the model and to have some, economical retribution from what we were doing. But very quickly, we realized that the business model wasn't going to be sustainable for all the investment we have to make. We didn't find the proper funding, at least in our country. So we decided to go through a patent in the US. And we started the patent process, but we financed it ourselves, the doctors and the designers, with our own money, and with the idea of selling this patent to another big company that would be interested. But later on, we thought, well, maybe that is going to be too complicated, and it's not going to reach the population that we need the invention or the innovation to reach. So we decided to change and say, okay, why don't we develop the model, and instead of selling it to anyone, we just put it on a 3D printing model and give it open access to everyone in the world that can maybe or possibly use it. And that's our final idea, is to improve the device, to have it properly working. We have run the first, and now we are doing the second clinical studies, and then leave it as an open source for anybody needing it, just to use it.
Amazing, thank you. And for those of you interested who maybe this is the first time you're hearing about open source low-cost medical devices, there's actually a whole repository online which we can share when we share the YouTube link of teams from around the world like DASON, which has done this. And I think it really makes innovation accessible in different parts of the world. It's a completely different model, but is very, very worthwhile. So thank you very much for sharing that. We have got 2 questions. So Estefania Ortega asks, she says, congrats on the project. She would like to ask the team, what experiences and findings have you had in the new or latest clinical studies of your project?
Yeah, happy to answer this. So we've been really, really lucky to have had really like positive feedback and results in the latest clinical studies, which I think speaks to the importance of kind of doing our initial proof of concept study like 2 years ago with that initial prototype that we showed that had like multiple pieces to it. And we found that just within 2 weeks in 10 patients, the potential was there, but you know, like I mentioned, the device would tend to like come apart, particularly like in some instances, for example, when the babies would move, or when they would like touch, when they like manipulate their tube too much. And with that feedback from kind of that initial study, we really focused on, okay, like if we want this to be a viable frugal innovation, if we want it to really touch the lives of these patients that we want it to serve, it needs to be able to be durable, obviously, and it needs to also be easy to use. So it can't have that many parts. So what we did in the past 2 years with kind of our entire team was really think about how can we like kind of redesign our device. And the new device that we're using right now is like greatly improved. It's like a one part silicone body, as well as just like a 1 part cap. So like overall it's only 2 pieces. And we've really harped on the idea of like having really robust mechanical testing, so we know that it won't break apart no matter how much like a little baby tugs on it. And then because of that, I think because of this like the meticulousness in which we have tried to kind of really design for some of the feedback, this time we've really received like really good in general, like pretty good feedback. We've had some of our patients and caregivers right now are telling us that it really does improve like the securement, like in comparison to previous methods. So there's now less filtration than earlier. There's less irritation around the stoma site, and the tube itself doesn't tend to move up and down, doesn't tend to migrate anymore when you just kind of pull on it or it gets caught on something. And in addition to that, not only is the securement part better, the part where you actually like the extra advantage of the device where you can like roll the extra length of the tube around the device, that has actually helped a lot of the kids from like preventing them from like pulling on it, from biting on it. And overall, like a lot of the caregivers have mentioned that they would definitely use this again in the future. Yeah.
Great. Thanks, Kathy. How many people were in your latest study out of curiosity?
Yeah, currently we have 20 patients. It's 20
20.
patients and for a month, and right now we're kind of at the 3-week mark.
Okay, wonderful. Thank you. So Patricia, there's a question in Spanish. Do you want to take that one?
Yeah, you want me to translate it or should I? Yeah, okay.
Yeah.
First, I'm gonna read it in Spanish. Felicitaciones, ha sido una muy buena oportunidad la colaboración desde el Hospital Josefina Martínez y la Universidad Católica de Chile. Quiero preguntarles cuáles han sido las principales ayudas y obstáculos en llevar a cabo en tu proyecto. And the translation is, congratulations, this has been a really good opportunity for collaborating from the Hospital Josefina Martínez and from the University Católica de Chile. I want to ask, what have been the principal obstacles and principal
Facilitators.
facilitators for leading the project? Do you want us to answer this in Spanish or in English?
Let's do both, I think. How about we start with Spanish?
Ya, en español, bueno, claramente las principales ayudas que hemos podido recibir han sido de parte desde la Facultad de Medicina de la Universidad Católica, la Facultad de Diseño, la Facultad de Ingeniería acá de la misma Universidad Católica y también el Hospital Josefina Martínez que nos ha podido facilitar el que podamos desarrollar los estudios clínicos en allá donde están ubicados y nos han prestado toda la ayuda necesaria de parte de los enfermeros, de parte de los doctores, de los TO, de todo el equipo médico, que nos ha dado una muy buena bienvenida a hacer el estudio clínico y que ellos han sido los que han, no solamente los pacientes, han sido los que han logrado tomar experiencia del uso de DASON, sino que también los mismos, el mismo personal de la salud que está trabajando ahí son quienes manipulan el dispositivo, por lo que ellos también han tenido un acercamiento bastante grande al proyecto y ellos son los que finalmente nos entregan el feedback más directo de cómo está funcionando o no el producto. Y los obstáculos a llevar, bueno, acá en Chile, lamentablemente muchas veces cuesta llevar a cabo estudios clínicos por la cantidad de trancas que uno tiene con ética, con coordinar todo para poder llevar a cabo un estudio clínico. Y ahí mismo entra el doctor Patilo, el Hospital Josefina Martínez, que nos han ayudado de muy buena manera para poder lograr superar todos esos obstáculos. Y también bueno, ahí mismo el hecho de estar trabajando con niños y necesitar, o sea, y lograr contactar a padres, lograr contactar a los cuidadores que nos den el permiso básicamente de poder trabajar con ellos también ha sido un obstáculo, pero de nuevo, muchas gracias también a la doctora Barja, a Loreto, que nos han ayudado con todo ese papeleo, por así decirlo. You want to ask to answer?
Yeah, and I can take it from essentially the English side. So in general, like the principal like facilitators, the help that we've received, as well as kind of the obstacles in realizing this project. So I think like one of the biggest helps I think that we could have done is just really getting a lot of like local collaborators and having a multidisciplinary team. You can see that this project not only has kind of a design component, engineering component, also very well has a very real like clinical component as well. And even within the clinical component, we're doing both like a clinical study in patients as well as like user focus groups with like staff and caregiver and providers. So like in order to really like fully be able to execute in these different branches, we've needed kind of the support of a really multidisciplinary team. So from the design team, the engineering team, the clinical team, everyone kind of like puts in their own expertise. And I think because of that, we've been able to be successful. Other things some obstacles that we've encountered in kind of realizing this project. I think one off is due to the nature kind of like international collaboration, like one, we really do kind of get the richness of like different cultures and different geographies. But there also is a little bit of the bureaucracy in terms of like going through ethics approvals and going through some of the logistics in countries and in not only just the US and Chile, but also within Chile, we have multiple clinical sites and multiple like actors essentially involved. So not only the Catholic University of Chile, but also Hospital José María Martínez, which is like a separate site. So just like being able to um kind of like predict and work ahead on these approvals is something that we've tried to do as a team. But even then, one of the biggest learnings, the team has had is even if you plan super far in advance, obstacles are going to come up like 2 days before you arrive in Chile. And that's just something that you have to, you know, just you're gonna get over. You just kind of face, you stay calm, you reach out to kind of the mentors that you have, and essentially we'll get through it. So kind of like that was one obstacle. And then another one that Patricio had mentioned was in general recruitment. So getting 20 patients was not necessarily an easy task, I think, especially because our patients were decently complex, from this like public/private pediatric hospital with like where the children kind of were there all the time. Their parents weren't necessarily coming all the time to like come visit. So because of that, we did have to get a little bit like creative in ways to contact like parents. So a lot of times parents would sometimes come to like there's like a little like mini school program or activities at the hospital. So we would try to like catch some parents there and explain to them the study there. Or we would also like call some parents, which was like in our approvals and all that. So just kind of like creative ways in order to engage the like community we want to work with here is also something that we've learned.
Thank you both. We have another question here about how has the product's material evolved, especially since it's used in healthcare, and given that 3D printing can sometimes be fragile.
Well, since we wanted to make an open source product, it's really difficult for us to start working directly with 3D printing because we know it's available in most parts of the world, but you don't usually like involve 3D printing in medical instances because of the nature of 3D printing. It's not used to it's not used to be a really good material for products that you want to last and to be hypoallergenic and to be washable and stuff. So yeah, that was really some difficulties that we needed to come by, but now we are working with PP, the polypropylene, for the plastic part. That it's a material that's really difficult to 3D print, but we came to a understanding of how to 3D print it and how to give that information, not only for us to 3D print, but to a way to give that information to anyone so they can 3D print it in their facilities and have the DASON dispositive in their hands. And for the silicone part, is as always has been a printed 3D mold with a medical silicone that it's also surprisingly available really easily around the globe. So yeah, that's how that's how the materials have evolved for the DASON project.
If someone wanted to find those files of product details, where from the open source, deposits, where could they find it?
Right now, we don't have it published yet because we're still giving it some workaround so that it's easy to make, print, and even iterate. If someone else would want to make some changes to the product, of course they can. So right now we don't have it. I don't think we have a specific plan. Will you say, Kati, to publish it, but probably publish it in Stanford, UC pages and stuff like that.
Yeah, we hope to ultimately make this technology available open source. As we know, one of the key tenets of frugal innovation is that it's available everywhere, and especially for communities that need it. So it's really important that this stuff is accessible. Because we're currently doing our clinical study right now and we haven't wrapped it up yet, we also are doing finalizing some mechanical tests. We're waiting for kind of those results and those data so we can kind of get the feedback from the users and from all that testing and use that to make some improvements to our prototype. We think our prototype is mainly finalized, but there's always, things that can be improved. So we're going to make those changes and then hopefully then kind of think about how to make a little bit more changes to make these our designs basically optimized for open source and optimized for other people's 3D printers and other people's silicon casting methods. So we do envision kind of in the near future, it shouldn't be that long, maybe in the kind of the next year or so, we would love to kind of have this available open source. Another thing is we recently actually published a paper on our first study, kind of the study that we did 2 years ago. And in there, it talks a little bit about kind of what the device looks like, a little bit about its design. So that initial design is already available. Obviously, the design we have now is a little bit more improved, but at least, communities have something to start with.
Thank you. So
Yeah.
I'm curious, one of the things that we wanted to touch on in this webinar that you've spoken about a little bit is that it's such a wonderful opportunity for students to get involved in global health projects. However, sometimes there's real harms when we see students get involved in a project and then, they graduate or leave and the project then stalls. And we've also, I think, the global health community has seen concern around students doing projects for credit and then not pursuing it. And you have a beautiful example of the complete opposite. We see, Kathy, how long you've been involved, and it sounds like the student team you've built is really committed and you've figured out a way to manage this complexity. Could you give some advice to any students that are listening to this or to the recording? How do they get involved in global health projects in a responsible way to ensure that they can contribute where they can, but that the project still continues once they've graduated?
Yeah, I think one of kind of the biggest learnings I've had is essentially build a team that kind of lasts beyond yourself, kind of know your limitations as a student. I think, as students in general, we have a lot of overall try to have a lot of energy, a lot of motivation. And with that, we bring on mentors that help support us and stuff like that. But at the end of the day, we also will eventually move on and go into different places. So I think bringing in especially a lot of local contributors and local students, for example, Patricio, we have other students on the team, Felipe, Catalina, just having them as, really invested in the project and essentially knowing as much as I do ensures that no matter where I go ultimately, I think the project is still going to be there and we're still going to be able to kind of make a difference in lives of patients. Another thing I think is the importance of mentorship, and really seeking out the right mentors and keeping up those relationships. So knowing that as a person kind of involved in the project, the responsibility lies on you to ask for support, to update your mentors, to ensure that they are constantly involved and updated on what you're doing. And I think that helps also kind of create a good link between everyone in the project, so that everyone is consistently invested and able to trust you and see tangibly the progress you have made. And I think that allows for kind of this longitudinal relationship that we've seen in this project here.
Thank you, Kathy. Please keep asking questions for those of you online. Dr. Patera, I have a question for you. So our biodesign community is global. We have people from all around the world in many institutions. And one of the things I'm interested in is, how do people build collaborations with each other around the world from different institutions. So do you have any advice or input as to how your experience has been from an institutional perspective with this project? Was there any contracts that needed to be signed, or did you have to formalize the affiliation with Stanford? How do you go about building institutional relationships for this type of work so that we can have innovations that cross-pollinate geographies?
Yeah, I reckon, Sian, that's a very good question, because one of the difficulties we do have to go through is all the paperwork and agreement, and because there are some funding involved here, and we need to be very serious about how we spend money directed to improve someone else's health. Okay, so this is highly regulated, but even though this is very bureaucratic, it shouldn't be a major challenge. It's part of the deal that it is. We need to go through it, and that's fine. And many times we have to give, I remember Catherine, when she just arrived, said, okay, you have some money here from our department to buy the Foley catheter for the first tests, and then we see how we reimburse that, and that's fine. But when we are having a major funding now, and we are involved in ethical committees and patients care, and taking it very seriously, we have to go through each of the steps that each institution asks us. So I have to present our protocol for the clinical trial in the university at the Hospital Clínico Josefina Martinez, and also it should be approved by Stanford. And that's fine. That's the way things should be done. So that's okay. But the most important thing is the genuine interest of collaborators. And for example, in the case of Catherine, we had a chat early on 2021, 22, I think. And she came to visit us, and we started with a small trial first, and we saw, well, this is going to work. And then we start exploring the next steps. So I think my best advice is to answer your emails, because you never know who is on the other side of the screen.
That's a beautiful piece of advice, Dr. Patillo. And I also love the fact that you mentioned Kathy came to visit, because I think that's such an important part. And, working in very different contexts, you actually have to have insight into each other's lives to some extent. And that Kathy wasn't just doing this via Zoom, I think was a really important part of this, because we often see collaborations where maybe context isn't shared, and then it becomes a lot more difficult. So I'm really glad to hear that. I have another question just around cognitive bias. So one of the things that we're also aware of as we think about frugal innovation is that there's this perception that, frugal innovation has largely been born out of need, where there's not the resources necessary. It's innovation to provide access to people that otherwise would not have received access. But if something works really well and is cost effective, we somehow limit it to thinking this should only be in resource limited settings. However, we also see the trends, particularly in the United States, in the UK, in many other European countries, where healthcare systems are becoming more and more expensive and at some point unsustainable. And so do you think there's a role for frugal innovation in settings where they may not be resource limited, but they may actually have different challenges with their resources? Once you've proved it's safe and effective, it should be for everyone, right? So I'm curious as to your thoughts there.
Yeah,
I think that's a big challenge for modern medicine, and we need to be very careful, because regulation can be very strict in the US and different in other countries. I remember my boss at the Wesley Children's, Dr. Albert Shun. He was a liver transplant surgeon, and he used ping pong balls, to in the empty space, that when you remove the liver of a child and put a left liver lobe, there is a hole there that sometimes the liver can turn and all the blood supply get challenged. And he thought, well, I can sterilize a big ball, put it there, and the liver won't turn. And he used that and saved one baby's life. But a year later, one newspaper published that, and then he was sued because he used a non-medical device in a patient. Okay, Foley catheter has been used for many, many years, but those are urinary catheters. Okay, but in an emergency setting, for example, when you get your the balloon of a gastrostomy burst and there is nothing else to use, you can put a urinary catheter there, inflate it, and leave it for a while until you get the proper catheter available. But probably even in the US, it would be how you say there can be justification to leave a Foley catheter for some time. In the meantime, you receive the proper gastrostomy tube, for example. In Chile, it's even worse. You know, the access for patients with gastrostomy who has burst the balloon and they lose the gastrostomy, the risk for the gastrostomy to get closed is higher than the risk of using a Foley catheter to keep the gastrostomy open. Okay. But answering your question, I think it's a challenge that you must see in your environment. And it's because there is something that we call in every country the lex artis. And lex artis means that you should do what you have to do in the conditions that you have. Okay? So probably for us, the lex artis is not wrong if you use a Foley catheter and an adapter that we are designing in our setting. But I don't know, in the US, it could be different.
Point taken, and I think that's something that we have to continue to have conversations about as innovators, as obviously innovations, frugal or otherwise, must always be safe and be well tested. And how can we use ingenuity and innovations like these to give access to people in very different settings? May require different contextual paradigms of what that means, as you said. So thank you for bringing that into the conversation. We are going to have to start wrapping up. I just want to say a big thank you to the team who presented today, Patricia, Dr. Theo, and Kathy. Thank you for sharing your wisdom and expertise. It was wonderful to hear the story of how the project came about and the lessons. As I mentioned, we so seldom actually get to hear how a project was conceived. We often just get to hear once it's at the end stages. So thank you for sharing that. I wish you all the best with the rest of your clinical trial. And I look forward to seeing the open source repository coming out soon. And I hope that what you've done with this project creates more accessibility for the children who need it, both in Chile and beyond. And just thank you for the lessons you've taught us. I do also want to thank Antje, Deja, and Danny for helping us put this webinar together today. And I also just want to remind everyone, this will be our last webinar for this current academic year. We take a break in June, July, and we start up again in August, where we have our monthly talks. Those dates you will find on our LinkedIn page if you don't follow Stanford Biodesign on LinkedIn. You can also subscribe to the Bay Area Global Health Alliance newsletter. You can scan these 2 QR codes to find out more about them. And for those of you who may be unfamiliar with the Bay Area Global Health Alliance is, they're one of our partners, and they are not just limited to the Bay, but they essentially are a neutral convener where they bring big tech companies, startups, and academia together to talk about innovations that really push forward global health and ultimately equity. So I urge you to get more involved. And for those of you who are learning about Stanford Biodesign for the first time today, you can go check out all previous sessions on our YouTube playlist. We have some really amazing sessions from the year, and today's recording will also be there for those of you who would like to check it out. As a side note, you will also find on the Stanford LinkedIn page that our innovation fellowships for 26-27 are now open, and that's a 10-month residential innovation fellowship. And applications are open, I think, for the next 2 months. You can find out more details there, but we welcome international applicants for those of you joining us from around the world. So thank you again to the team, and I'm going to hand over to Patricia to close this off today.
Bueno, para terminar, esta es la última sesión del año académico y esta serie volverá en agosto de 2025. Gracias a todos por acompañarnos hoy Y si se perdieron alguna de las sesiones anteriores, pueden encontrarla en el canal de YouTube de Biodesign. También se abrieron las nuevas postulaciones para el equipo de fellowship de innovación de Biodesign, para que también lo revisen. Todo eso, toda esa información está en el LinkedIn y muchas gracias a todos por estar acá, venir a escucharnos y también por todas las preguntas y participar.
Great, thank you everyone. If I can ask the panelists to stay online for a photo, that would be great. But thank you for joining today's webinar.
Thank you.
Thank
you.
you.